Okay, it's time to look at part 2 of Healthy Families, the Whole of Life Community Healthcare module. We're starting now with Unit 4, which is around health for the whole family. The objectives of this module are to describe the rationale for the life course approach to family health promotion, especially its contribution to breaking the cycle of poverty. We will look at how we can counsel families on the nutrition needs for different ages and stages of the life cycle, how to assess the utilisation of essential child health services and counsel families on uptake of these services. There's 2 sessions on counselling the family who have adolescents regarding healthy lifestyle choices and uptake of services, and that includes 2 storybook approaches for different age groups which support parental education on the subject of adolescent health. We will also demonstrate how to assess the status of elderly care in the home and how to counsel the elderly client and their caregivers on how to look after themselves and how to make sure that they take up routine health services. And lastly, we're going to go through how to demonstrate or how to actually correctly complete the household and family health assessment. So we're going into session 1 and we're going to take a look at the activity related to the leaky bucket exercise. So this is an activity that describes the rationale for including a comprehensive family health approach. And the leaking bucket is a very good metaphor, and this is a way that you can demonstrate in the classroom which really highlights the futility of making early life contributions that are lost later on. So we think about the Millennium Development Goal era and the kind of interventions that public health practitioners did to invest in family health. They're very much focused around household health and hygiene, and also around maternal and newborn care and child health, so ICCM. But those early investments were not matched with the problems that children and young people and adults face later on in life. So for example, throughout the MDG era, there's been a very low investment on adolescents, and we've seen a steep rise in the rate of adolescent pregnancies and adolescent incidence of HIV and other STIs. There was also no investment in early child development, so children were starting school often having had very little investment in their own learning and development at home. So children and young people are not supported to develop their full potentials in life, and because they're not educated on health properly at school or later, they develop often unhealthy lifestyles, and they may also lose out due to poor mental health and well-being. So a great way to demonstrate this in the classroom, if you have a bucket with a tap and a basin and a jug, you can get the CHWs to start filling up the jug with investments in early life, such as vaccinations and growth monitoring, promotion and complementary feeding. But as you fill the bucket, you will see the water starts to leak out. So you can see that you need to continue working the same amount in every generation to just maintain a normal level of family health. However, if you stop the leaks that happen in later life, then we actually see that the family health bucket is filling up. Another great way of talking about this is the generational cycle of poor health and poverty. So what we mean by this is there is a vicious circle, and that poverty and poor health are transmitted through the generations. So let's start thinking about pregnancy, so the very start of life. So look at the top left-hand corner. Parents who are living in extreme poverty have low access to health services. They have lack of health knowledge. They tend to have larger families due to lack of access to family planning. And they also experience more marginalisation or lack of support in their communities. So they will go on to have babies who experience poor access to health and hygiene, and they have a less possibilities for early learning and development. Those babies then go on to become children and young people who have a higher burden of disease, poorer growth and poorer development curves, and as a consequence, in school, they reach lower educational attainment. So looking at these children growing up to become teenagers and young adults, those young adults, because of their lower educational attainment, because of their lower health in early life, they will experience lower access to jobs and higher education. They have higher rates of teenage pregnancies and also higher rates of infectious and chronic diseases, and will generally experience lower mental health and well-being. So then, as these people grow up, they become adults who have a higher non-communicable disease burden, higher levels of stress, low income, and are living in poverty. So as we see that this cycle can continue poverty through the generations, we need to think about how we intervene at each of these steps to try and make people able to break out of the cycle of poverty. So there's a virtuous cycle of health and well-being as well. So if we think about that, how parents who are educated and have high access to health services tend to have smaller families and experience better community and family support for health. They will have babies who are healthy and experience good hygiene and good nutrition, and will have opportunities for early child development as their parents are educated and know how to promote cognitive and social, emotional and physical development in their children. Those children will go on to have better hygiene and nutrition through their school ages, will have better education and play opportunities, and as a consequence have higher educational attainment. These young adults are then more likely to have completed their education, be protected from violence abuse, adopt healthier lifestyles, and are less likely to contract diseases such as HIV and STIs. So those adults become more able to have healthy lifestyles, access community support and job or income generating activities. So this is the virtuous cycle that we want to see in place. And let's remember as well that in our era, the Sustainable Development Goals era, we need to think about health not just as survival, but also its contributions that it makes to poverty elimination, education and economic growth of the population. So looking at your books, there is an activity in which we have listed all of the essential health interventions at each of the life cycle stages. So as you're projecting this on the screen now, what I'd like you to do is put those interventions on a post-it note and come up to the screen and place them on the generational cycle so we can see what interventions need to take place at each step in this cycle. Pause the video now and continue when you're ready. So I think what we really need to emphasise in taking this generational cycle approach is that we need to move away from our focus on the mother and the newborn care. That's been the focus for a long time, but we have let slip aspects such as adolescent child health, mental health and well-being, and also child development and child protection. So taking a whole of life approach, we will be trying to break families out of the generational cycle of poverty and give children and young people the best start in life so that within a generation we see conditions improving for everybody. So the next part in this session relates to the age cohorts and the key health issues that will be addressed through the Healthy Families approach. It's really important to take time with the village health workers to make sure that they understand these aspects. Importantly, we will be covering pregnancy and newborn care within timed and targeted counselling. In the childhood period, so the 1 to 59 months, half of this will be covered in ECD, but children from the age of 2 years to 5 years will be captured during the routine household visit. Children and adolescents are grouped here according to 5 to 19-year-olds. That covers all of the aspects and health issues there, but we'll be further breaking those down to look at specific needs of each age group. And then adults and youth and adults are covered here, And also we will be including care of the elderly. There's very high numbers of elderly people living in rural communities, especially now more and more living without adequate family support and poor living conditions. So I want to move on now to session 2. So session 2 is family nutrition, and in this session it's a technical session which explains the importance of good nutrition to our health. It describes the components of a healthy diet and additional nutrients specifically required during pregnancy and childhood, so we're emphasising that quite a lot. But it also it teaches the village health workers to assess nutritional practices in the household by all household members and to counsel accordingly. So for this session, because most of the content is very familiar to you already, we won't go through this session in depth. I think it is important to spend 5 minutes reviewing the technical content of the session and seeing if there's anything that is unusual or strange to you, or anything that you've not covered in your previous trainings. And then we'll go through the job aid in healthy families related to nutrition practices. So here is the family nutrition assessment, which is done as part of the household assessment. So we'll be looking for iodized or iodated salt in the family, asking the family if we can actually see and check the salt is iodated. Asking about food security, so do the family have a regular, reliable source of food, including, if appropriate, homegrown supplies? Do they ever suffer periods of time when they're forced to limit meals to less than 2 meals a day, or unable to provide more than the basic staple foods, or they are becoming increasingly dependent on food donations from any source? 3 food groups. So do the family regularly eat a balanced diet every day, including bodybuilding foods such as protein, meat, eggs, beans and peanuts, protective foods such as fruit and vegetables, and your basic energy foods such as staples, rice, maize and corn. In Lesotho, and as in many African countries, families that are in food insecure situations will tend to emphasise those energy foods with limited protein-based foods. Also, many families don't understand the importance of fruit and vegetables and increasing their fruit and vegetable supply even though they have access. So it's important that the village health worker look at those issues. Iron-rich foods. Remember that iron-rich foods are very important for children and for adolescents and for pregnant and breastfeeding women in particular, but all family members should have access to some forms of iron-rich foods. So those may be meat or dark leafy green vegetables, and eggs and other sources as well. Remember, they can also access iron fortified staple foods such as iron fortified maize and flour. Home kitchen gardens. So this is part of our food security assessment, but it's clear that families who have access to homegrown foods can improve their own diet directly through creating bodybuilding foods such as beans and peanut that they wouldn't otherwise have access to, and also vitamin A rich foods like carrot and iron rich dark green leafy vegetables. So those are the elements that will be assessed, and then we'll tick on the card which of them they are currently achieving. Then we just want you to have a look through the pages of the job aid. So this is the key instructions for each age group. We've put them all together here so that nutrition can be considered all together. So in terms of routine feeding of infants, we're just looking at breastfeeding. And then we've got the child aged 6 months to 2 years with different types of food groups, and also looking not just at diversity but the amount of foods per day, and what types of foods are suitable for children between the age of 2 years and 5 years, and what amount of food they should be having. Also to encourage a mother to actively feed, encourage children to feed themselves, provided that they also wash their hands with soap before you. And then for nutrition in adults, we've just provided here the key messages. So adolescents, it's really about setting them up in life to make good healthy food choices for themselves. Includes intake of fruit and vegetables. The key recommendation there is 5 portions a day, but at least 3 portions would be adequate. We encourage them to avoid sugary foods, fizzy drinks, sweets, and of course alcohol. All of those contribute to the higher risk of diabetes in later life and obesity. Increasingly, we see adolescents, especially in towns and cities, are very drawn to high saturated fat and high sodium fast foods such as burgers, chips, fried chicken, and fast foods. And then lastly, all adolescents, but especially adolescents, girls, need iron-rich foods in their diet. The pregnant breastfeeding mothers, we would have covered this already in TTC. And then we look at adults and the sick, and also the elderly in terms of how they're eating. This is a summary of the texture and frequency and amounts of food that should be given. So now we're moving on, once you're ready, to session 3, which is routine care for children aged 2 to 5 and 6 to 9 years. So these are the key health recommendations for children aged 2 to 5, and these are the questions that would be covered by the village health worker during their household visit. That's on the job aid. Also on the job aid, we have a special focus on deworming and vitamin A that should be done 6 monthly for children up to the age of 5 years. Growth monitoring is particularly important, so children up to the age of 5 would be regularly monitored at the health facility for their growth, and their growth curve should be tracked. Village health workers need to check this during every routine visit. Vaccination. So vaccination should have been completed before 2 years of age, but we've just got a reference card here which shows what the key vaccinations are in Lesotho. Okay, I want you to take a close look at this table that's in session 3 and spend some time with the village health workers really going through the main problems and risks, preventive health practices that they should be teaching caregivers, what services the children need to access, and also, most importantly, this last column, which is the developmental needs from the family and community that children have at different age groups. So the 0 to 2 group we have largely covered in TTC, but it's put here for the purposes of comparison. So let's have a look at the main health problems in children. So They're fairly consistent across the 0 to 9 years age group, with infectious diseases and parasites and malnutrition being the key causes of ill health. However, as the child gets older, the contribution of violence, injury and the effects of abuse or neglect become more and more important. In terms of preventive health practices, we're really focusing in the young ones around establishing good nutrition and breastfeeding. Also, hygiene and safe drinking water, and making sure that parents are able to detect those danger signs in diarrhoea and pneumonia in particular. As the child gets older, many of those continue around healthy nutrition, hygiene, breastfeeding and detection of early health problems. Early childhood development, stimulation and play also become increasingly important, as does enabling a child to have healthy physical activity and to use their energy well throughout the day. At the 6 to 9 years group, we're also focusing on the social aspects of health. However, with this age group, those who've been infected by HIV through vertical transmission will need to be disclosed to, so we can help them to understand their medications and how and why they're taking them, and also to understand their condition and what kind of health practices they need to establish to keep themselves well. At this age group, they're still very accessible to their parents, so parents establishing an open atmosphere of communication will be really, really good for the children as they head into adolescence. Parents might actually take a slightly laissez-faire attitude at the 6 to 9 age groups, allowing children to go out together to have unsupervised play, but unfortunately that is associated with increased risk of injury, particularly in Lesotho, as we heard, where there's lots of risk of children playing on cliffs and things like that. So it's very important that parents understand that this age group, the play still needs to be supervised by an adult. In terms of health services, we see fairly consistent need for health services across the life cycle. In the 6 to 9 age group, we're really reinforcing the importance of school enrolment and 100% attendance rates. Partly because of their learning opportunities, but partly because of the health programs that will happen there, such as vaccination, also receiving school meals that usually include fortified foods, and access to comprehensive sexuality education that's introduced in an age-appropriate way. Let's look now at the developmental needs. So we started in the ECD session for the 0 to 2s, and we really saw the importance of sensitive and responsive caregiving. So that's serve and return for establishing good attachment and bonding with the caregivers from an early age. The child also needs to be protected from any physical dangers, and that could mean hazards in their environment, but it could also mean hygiene. Parents need to work to promote good language stimulation through singing, telling stories, using books, and just enhancing that vocabulary to grow really quickly. They will start to develop a need for self-control. So under the age of 2, they'll be expressing their emotions in a very uncontrolled way, but gradually they need to understand those emotions. And part of that will be catered for by enabling opportunities for social play. So that means getting babies together and getting them to play together. But in the 2 to 5 age group, we need all of those things, but there's going to be increasing need for the acquisition of ever more complex skills. So parents need to identify toys that stretch the children, that help them to solve problems. Things like puzzles are very useful, as are building blocks or nesting cups, things that children can do to try and solve difficult situations. Paper and pen is also really a great toy for this age group, because they can start to make marks on the paper that establish pre-literacy skills, holding a pen and drawing pictures, etc. So in this age group, we know particularly about the tantrum era, which tends to last from the terrible 2s up to the terrible 5s. So most of children's tantrums come from their desire for independence. They want to do things all by themselves, and often parents resist that. they want to make their own choices, and parents will restrict them, and toddlers will fail to understand essentially why they're being so restricted by their parents. So helping parents to understand that need for independence that children have can hopefully divert some of those tantrum-like behaviours. So allowing children to do tasks for themselves, or if you want to stop them doing something, present them with alternatives so that the child still feels that they have autonomy and independence of decision making, although you're restricting what they're actually doing. Pre-literacy skills include things like learning the alphabet, learning the letters and phonics or sounds, and also holding a pen and starting some basic writing skills. At this age, children love to play with each other, and they will engage for hours in imaginative play, which is really healthy for social and emotional development. You should encourage children to know what their identity is. So typical activities in this age group involve drawing pictures of themselves, of their family members, of the people that they love and who love them, where they live, etc. So this is a way of establishing who that child is, their sense of identity. In the 6 to 9 age group, school attendance becomes critical, and that's not just about their numeracy and literacy development, but it's also about social interaction with their peers, from which they learn a hell of a lot. They develop a sense of identity and confidence, and a sense of personal competency, as in what are their talents and attributes and things that they are good at. But all the more important that as they are developing their own lives, they can come back home and have a good communication with their own mum and dad, and that there's always a level of trust that is established there, that parents feel they're able to speak openly to their children about any topic, and that children always feel that they have someone to turn to. This is where they start to really acquire important life skills, such as developing friends and relationships. So this slide is in your book around the activities that parents can do to make sure that they have better communication. Certainly in Lesotho, when we did field studies with parents, we found that often parents didn't really feel well equipped to have good communication with their children. So here's some basic skills around listening and talking to your child. And you'd be surprised how useful these little simple techniques are in getting good results and making sure that children behave, follow the disciplinary processes of their family, but also feel loved. They feel cared for. An important part of that is that they're given a chance to express themselves and be heard by mum and dad. So, the key messages from session 3, we've covered a lot of topics. So, the essential services for children aged 2 to 5 are designed to protect them from illness and from malnutrition, and help build up the positive cycle of good health and growth. So that includes essential health services of immunisation, vitamin A and deworming, and growth monitoring. Parents of children under 5 should make sure that they teach and practice hygiene and disease prevention measures in the home. So oral hygiene, so brushing teeth at least twice a day, making sure children wear shoes out of doors, and hand washing with soap at 5 critical time points. Children should be able to progressively do this for themselves. In terms of school-age children, so looking at the older age groups, they still need that support to ensure hygiene and personal care and good nutrition, but they will be taking on more and more of those tasks for themselves. They continue to have a need for growth monitoring and deworming throughout school. From the age of 2 to 5, child mental development can be promoted by stimulating language, sensory motor development through problem solving and toys, and also assigning task responsibility. So that means giving the child more and more responsibility in the tasks that they can do. And also promoting early literacy through using stories and pictures, pen and paper. And also parents need to encourage play with peers, which is the socialisation. Make sure that that play is supervised up to the age of 9. From 6 to 9, children are developing literacy and numeracy, as well as their sense of who they are. So the most important thing here is that children are in school, but parents should also engage with the children about their learning at home and encourage them to develop their own sense of identity and self-confidence by trying out different activities in the community that they might get involved in. that are healthy ways to develop a sense of self. Open parental communication is encouraged from an early age. Village health workers should teach parents how to adopt positive communication skills, including those essential listening skills and how to talk to children so that they will listen. Okay, so we're moving on to the health of adolescents. So there are 2 sessions on health of adolescents, partly because it's just a very large amount of content, and partly because one is more technical and the second one is more practical. So in session 4, we're going to be describing the importance of adolescent health and the stages of adolescent development. And we will list the important health services and behaviours that are promoted for adolescents in the household visits and why we've chosen those. We're going to talk about the common health problems that adolescents suffer, and also what are the concerns that adolescents actually have themselves. So when would an adolescent seek health services? So, and then teach the village health workers how to make appropriate referrals for those cases. And we're going to discuss barriers and motivators for adolescents. The critical health behaviours are around changing adolescent health behaviours and choices. So it's really important that we try to understand the adolescent mentality when it comes to encouraging them to adopt positive health behaviours and to seek care when they need it. So I think for session 4, what you need to do is stop the video now and actually conduct the session. Most of the activities 1 to 4 are new technical concepts, so you can review those and look at the key health elements. And then when you get to activity 7, I actually want you to break out into groups and conduct these as case conferences. So each group can take a different case, and then you can sit and discuss for 5 or 10 minutes and then report out how the village health worker should respond to that case. So before you do that, I just want to give you a brief overview of the WHO framework for adolescent health. So this is the sort of key health needs of children and young people. So we can see that the main health needs relate to HIV, across the top, HIV, violence and injury prevention, sexual reproductive health or maternal care, so that's particularly around adolescent pregnancy, mental health conditions, remembering that from 15 to 24, self-harm and substance use, as well as suicide, are key health burden issues for adolescents and young people. Across the bottom, we need to look for basic nutrition, making sure that children and young people have good education around adopting a healthy diet, but also that their diet is adequate in the key nutrients such as iron and folic acid. Physical activity should be established in adolescents really in order to have a lifelong effect on their behaviour. For tobacco control, it's about cessation of those who have started or experimented with tobacco, but also alerting young people to the problems of tobacco use and the kinds of problems that can cause in later life. And then the last 2 around the management of common conditions and vaccination. So what do you think a village health worker can contribute to? Pause the video now and highlight the areas that you think village health workers should be addressing in Lesotho. So HIV is a key problem in Lesotho, and village health workers have a special role in ensuring that those HIV services are made accessible to teenagers, and that's regardless of the parental knowledge or support. It's really important that children are able to access the medication that they need on time. So the first one would be HIV counselling and testing, so making sure adolescents know how, when, where they can get those testing services. Voluntary medical male circumcision is going to be important across the age groups in boys. Access to prevention of mother-to-child transmission, particularly for pregnant adolescents, and accessing treatment and contraception. to prevent HIV infections. So within TTC, you see there was a particular emphasis on adolescent pregnancies, and village health workers have a really special role to play in preventive care and education, so that and also that support in pregnancy. Adolescent pregnancies are particularly at risk of unsafe abortions, which in the context of Lesotho are illegal, but we do know that they're very, very high risk unsafe abortions, especially where they are illegal. They'll be happening behind closed doors, they'll be happening without any access to hygiene control. So these are the things that village health workers really need to be sensitive to in early pregnancy of an adolescent. In terms of accessing health services and healthy lifestyles, there are roles that village health worker can play in promoting good nutrition. They can also distribute iron and folic acid for teenage girls in accordance with their country policy. Physical activity can be promoted through home visits, and this is done through parts of healthy lifestyles in the context of the village health worker work in Lesotho. Immunisation will largely be about community mobilisation and educating parents so that they access those vaccines. So we've identified a number of essential actions for adolescent health for caregivers of children and young people. And these are all very evidence-based. So the first one is that the most important protective health intervention for children under the age of 19 is to be in full-time education or an equivalent program of study or a skills-based apprenticeship. Any child who is outside of full-time education should be considered to be a vulnerable adolescent, for the reasons that they won't have access to the same kind of life skills preparation, and they're often fending for themselves in terms of nutrition and conditions at home. They should all have access to comprehensive sexuality education and life skills training. It's very interesting to have learnt from the last 2 decades of adolescent health programs what's been successful and what hasn't. It's also very clear from the evidence now that peer-based learning is not successful. It's not a good use of funds for promoting adolescent health. Basic sex education in schools that just focuses on informing children about the risks of HIV and STIs and the risks of adolescent pregnancy is totally insufficient as well. So having the knowledge is quite different from having the skills. Comprehensive sexuality education is a program in which children are encouraged to develop the skills and confidence to actually assert themselves in a situation where they need to use contraception. And making sure that if they are choosing abstinence, that they have the negotiation skills that they're required to do that. So it's much more than just sex ed. Comprehensive sex ed is a really holistic approach that is very evidence-based and effective. They should be protected from HIVs and STIs and unwanted pregnancy, have access to tetanus and HPV vaccination in accordance with the policy, have a healthy balanced diet and access to opportunities to do physical exercise and healthy social activities that encourage them to develop a sense of identity. So those are the ones that we're going to be focused on. However, there are also those priority interventions for family planning, HIV, and also particularly for providing HIV treatment support to young people. So I want you to stop for a moment now, pause the video and ask yourselves the question, who are the most at risk adolescents in Lesotho? Make a list of those on a flip chart. Then, once you've got that list, I want you to ask yourself the question, what role does the village health worker potentially play in providing services, giving psychosocial support, ensuring access to sex education, comprehensive sex ed and life skills, and then ensuring access to family planning, HIV and treatment services for the most at-risk adolescents, especially those who are out of school. Proceed with the video when you are ready. So hopefully you've had a chance to go through some of the technical content on adolescent health, and you will have learnt about the key health problems and issues that adolescents have, and secondly are likely to seek help for. So much of the adolescent health issues covered here are related to adolescent behaviour, risk behaviours and choices that they make. So children who develop good adolescent behaviour, these are the areas that we know are really important. First of all, families matter. That means that adolescents who have a positive relationship with their parents are less likely to start sexual intercourse early. By a positive relationship, I am talking about that open communication style, a level of trust with their parents, parents setting clear boundaries and making clear expectations, but also enabling children to have a sense of choice and independence, but being supportive of them making those good choices. Schools matter. Adolescents who have a positive relationship with teachers are less likely to start sexual intercourse early and engage in risk behaviours. So schools are really critical importance, so parents should be encouraged as much as possible to get their adolescents to stay in full-time education to the age of 19. Friends matter. Adolescents who believe that their friends are sexually active are much more likely to start intercourse early. So who your children are friends with is a very important determinant of their own behaviour. Beliefs matter. Adolescents who have spiritual beliefs are less likely to start sexual intercourse early. That's really important that children develop their own sense of spiritual identity. It can be one thing to encourage children to participate in a church with you, but allowing them to have access to age-appropriate groups such as youth groups within the church can be really strong in developing really positive friendships and also exploring their own spiritual beliefs as a part of forming their own personal identity. Remember that all risk behaviours are linked, so adolescents who engage in any other risk behaviours such as alcohol and drugs are also more likely to have risky sexual behaviours as well. And not to forget that adolescents acquire certain risk behaviours from their parents. So the use of alcohol and drugs and smoking in the home by the parents means that adolescents are much more likely to adopt those behaviours for themselves. So what kind of positive practices and attitudes should parents adopt to protect their young people? They need to encourage children to avoid high-risk areas, to keep good company and have positive peer support. Make sure that they have access to healthy and safe community activities, sports, choir groups, youth groups, whatever they are. Community participation is an important part of establishing their own identity and staying healthy. Help them to set healthy boundaries in relationships as they are starting to develop relationship skills. Encourage them to say no to alcohol, drugs and any kind of gifts for sex, which is very, very common in the Southern African context. Encourage them to report suspicious or inappropriate behaviour to adults, and particularly to their parents if they trust them. Help them to understand risks and consequences of particular behaviour, but more importantly, take a positive attitude. So enable them to set some really clear life goals and aspirations that they can have and they can work towards. That makes staying away from risk behaviours and drug and alcohol use much more of a positive and proactive part of establishing their lives. Help them identify opportunities for healthy fun and recreation, and set them a good role model through your own behaviour. There are lots of barriers for adolescents, so there's an influence of their peers that is very difficult to overcome. Parental expectations can often be too high for their children, and children also are seeking to pull away from their adults and have this persistent desire for independence that adults need to understand. Most adolescents say that they don't feel that their parents support them, and that they don't feel that there are positive relationships in their school or their churches that support them and their decision making. They're very, very fearful of rejection. So often they will refuse to tell their parents or their teachers about things because they're afraid of the consequences, which could mean being rejected by mum and dad. Increasingly, we see media and social media influences on children, which are influencing them to adopt unhealthy behaviours from an early age. So we need to look at the media that they have access to, and where possible control their interaction with social media, or at least encourage them to be open with parents about how social media is affecting them. Other issues are much more structural, so lack of recreation facilities, lack of access to healthy and fun community participation opportunities is a real issue, as well as poverty, which can affect young people in a variety of ways. One of the things that's really key about parents is that they just fail to understand what is happening to their teenagers. They have often forgotten what it was like to be a teenager themselves, and they failed to adopt that attitude with their children. Also, they tend to transmit the behaviours that they've received in adolescence. So if their parents refuse to talk to them about sex and drugs and alcohol, they'll do the same to their children. Most importantly, parents think that these problems happen much later than they really do. So in Lesotho, for example, the average age of sexual debut is under 15, but most parents perceive it as being 15 or older. In fact, a large percentage of children have already had sex before the age of 13. So how do adolescent perspectives change throughout adolescence? So at the age of 10 to 12, children tend to see themselves as children. They're still very close to their parents, and so they're hesitant about making their own choices because of that parental dependence. When it comes to issues like HIV, they're not really taking it on board as a personal risk. They have a low sense of mortality, and they have a high need for parental love and parental affirmation still. But at the age of 13 to 14, and often very abruptly, they can go through a change. So they start to challenge authority, and they want to assert their rights and their opinions. They will begin to pull away from their parents and stop thinking of themselves as children. They will often actually say this to their parents: "I'm not a child anymore." They feel that they are capable of making their own choices. They also have a sense of arrogance, so they often think that they know more than they actually do. They don't have a very good sense of their own mortality, so they won't see HIV and other risks as being a personal threat to them. However, they're not as smart as they like to think they are. They're still extremely vulnerable to misinformation, especially when they're engaging with older children or adults that may be able to manipulate or coerce them into doing things. They look more and more to their peers for affirmation. It's really important at the age of 13 or 14 to be very popular at school and to be accepted by their peers. So the fear of embarrassment becomes one of the most acutely motivating aspects in this age group. However, they still need parental love and guidance, even though they don't know that they do. And during this age group, they're really progressing with the developing sense of identity. They get their sense of who they are. But don't forget, between the ages of 13 and 14, biologically and hormonally and physically, there's a hell of a lot going on. So this is a really vulnerable age group. Okay, moving to 15 to 19-year-olds, things have progressed again. So at this point, they really start to see themselves as young adults, and they want to be treated by others as adults as well. So they're very sensitive to the ways that their parents and their teachers speak to them. Inevitably, at this age, if parents are still speaking to their young people as though they were children, there's going to be conflict in that relationship. So they want to be spoken to with respect. They want to be reinforced in their ability to make their own choices. but more and more they want to explore things for themselves. They still have a low sense of their own mortality, so the risk behaviours won't be a massive deterrent for them. But there's a very high risk of unwanted pregnancies and STIs in this age group, so it's really important to help them to make healthy choices, but make sure that they have access to the health services that they need and to family planning commodities. They're often really resistant to parent and adult interference because they have a developmental need for independence. This is not just about children being difficult. This is about children undergoing a natural process of pulling away from mum and dad and adults and establishing themselves as an independent person. So it's really important that as teachers, as health workers and as adults and caregivers, we are respectful of that process that's going on in adolescence. We do understand that they tend to be more secretive. There's also a very high risk of dropping out of school, getting involved in drugs, alcohol and smoking and other risk behaviours. However, if we want to protect them from that, we need to have established a very good foundation where they have a sense of who they are, a sense of identity, a sense of their own personal competency and skills, knowing what they're good at, knowing what their contribution is in society. And all of those things will be very protective for them in preventing these risk behaviours from being adopted. So I mentioned that I would like you to do activity 7 in groups. So pause the video now and take 20 minutes to have a go at that activity. Session 5 is conducting the home visit for adolescent health. So this is where we learn about how to conduct the evaluation of health actions for adolescents with parents. We will describe the key messages behind each of the essential health actions, and we will use the storybooks to lead a discussion on parental support for adolescent health. So here we start with activity 1. We're going to go through this session in detail. I want you to start in plenary having a discussion on the following questions. Firstly, what are the common health issues affecting adolescents between 10 to 14 and 15 to 19? They were covered in the last session. What are the beliefs and practices of parents which are helpful in supporting young people to stay healthy? What beliefs and practices might be damaging? How often is the routine integrated household visit done? And how often do you think we should visit parents of children aged 10 to 19 for this family health check? So here you see the components of the family health check. We're still focused largely on promoting healthy caregiving with parents. You can see that we've broken down this slightly differently because there are different health essential actions for the 3 different age groups. So the top set of behaviours, they should be promoted for all children from the age of 6 to 19. So this is not just for the 6-9 groups, this is for everybody. So everybody in this age group should be in full-time education, be supported to have a healthy diet, engage in physical activity, and establish open parent-child communication styles. Also, for the boys, voluntary male circumcision should have been done between the ages of 6 to 9. So the next 4 practices are directed towards caregivers of children aged 10 to 19. So the first one here is access to comprehensive sexuality education. If they're in full-time school, they should have access to this. However, those that are outside of school need to access this through community activities or through church or youth groups. HPV vaccine, human papillomavirus, is an important vaccine for girls between the age of 12 and 13. We will need to ask parents to show us the card and verify that the child has actually had that vaccine. This is a really important vaccine for preventing cervical cancer in later life. Community, faith and youth participation. So we are asking parents about what kinds of social activities the children have access to. If they are not currently engaging in any, we need to investigate what kinds of activities are available in that area and make connections and links so that parents start to support their children to have healthy activities. And then drugs, alcohol and smoking. We're asking parents about their teenagers' current access, but we also need to look at whether or not the parents have that in the household and whether they're protecting their children. When it comes to the 15 to 19-year-olds, we're really focusing just on the last two issues related to sexual health, which are consistent across the life cycle. So access to HIV testing and treatment and access to family planning. For this age group, it could be relevant for the village health worker to speak directly to teenagers aged 15 to 19 if the parents are comfortable and if the children themselves are comfortable to discuss it in their presence. Otherwise, we'll continue to focus on the caregivers. So now what I want you to do is conduct activities 2 to 4, and I want you to present the adolescent health storybooks. There are 4 stories, so 2 stories for the 10 to 14 age group and 2 stories for the 15 to 19 group. You'll see that these stories depart a little bit from the formula that we used in TTC, but that's relevant because it's important to address girls and boys slightly differently because they have very different motivators in terms of their health behaviours. Pause the video now and continue when you're ready. Okay, hopefully you've had a really good session on adolescent health and you've learned a few things yourself. It's time to move on to session 6, which is on care of the elderly. So this session is quite new topics as well, although many of you will be familiar with elderly care. This is a new role for the village health worker, which we are seeing an increasing need for in Lesotho. Due to urbanisation, a lot of the rural community is now predominantly elderly, and often they are looking after themselves with little or no family support as well. So let's start with activity 1 and discuss the following questions and brainstorm those in plenary. So firstly, what are the common conditions affecting the elderly? Have the conditions and care changed in your communities in recent years? What are the barriers to health that older adults experience in rural communities today? And also, what are the living conditions that may contribute to their poor health? Really important things to think about. Pause the video now and restart when you're ready. So, older adults, so those aged 60 or above, make very important contributions to society as family members, volunteers and active participants in the community. Grandparents and grandmothers in particular make very special contributions to child health and nutrition. Whilst many experience good health, older adults are at high risk of developing certain disorders like mental disorders, physical illness and disability. The most common health problem is actually mental disorders, and these affect about 1 in 5 people over 60 and include common illnesses like depression and dementia, but also anxiety problems and even substance use. These problems often go undetected and their sufferers and their families may not actually seek help. So if you suspect a mental disorder in an adult, you need to refer them quickly. Mental well-being in older adults is often affected by loss of independence or limited mobility due to pain, frailty and disability. Their sense of bereavement and widowhood as they lose their partners that they have been dependent on for many years. The loss of socioeconomic status and sense of value in terms of their community contribution. They're also highly vulnerable to neglect, abuse or abandonment by family members. And increasingly, we see older adults in rural communities suffering from isolation and loneliness. Dementia is an illness which causes loss of memory and the inability to perform some basic tasks. It is progressive, so that means it gets worse over time, and it affects many older people, although it is not a normal part of ageing. The most common form of dementia is Alzheimer's disease, and that's indicated by loss of memory and confusion. Often it's very hard to detect dementia in the early stages as older people will feel resistant to confessing or to disclosing to their family members that they feel a sense of memory loss and confusion. Also, it can affect moods, which may restrict their ability or willingness to seek help. Caring for an adult with dementia can put a strain on family carers and finances. There's no treatment, but support for sufferers and caregivers is really important to diagnose early and promote understanding and managing of challenging behaviours. Elder abuse and neglect. So the elderly are particularly vulnerable to neglect and mistreatment. That can include physical injuries and also exacerbating existing problems like depression and anxiety. Families can increasingly struggle to meet the care needs of an older adult, and they may neglect them in terms of supporting them to have good nutrition, hygiene. They may forget to take them for health checks, and they may fail to complete the medications and treatment that they need. Studies in Lesotho have also found that some more severe forms of abuse can occur, including violence and abandonment. Social issues such as domestic abuse, alcohol, and belief in traditional practices are also contributing factors. Malnutrition. So approximately 1 in 20 elderly people living in rural areas are suffering from obesity. That increases the risk of chronic health problems like hypertension and heart and lung disease. However, many more people suffer from undernutrition. Undernutrition is more common in elderly who have low education, low support and disability. Okay, disabilities. There are a range of disabilities that we need to consider in the elderly, including loss of mobility, vision and hearing loss. And these can severely affect their well-being and their ability to care for themselves and their ability to do income-generating activities. Hearing and eyesight loss are very common, and vision loss affecting around 1 in 8 people. This leads to a much lower quality of life and loss of independence and isolation. So access to ear and eye care and corrective devices and surgery, although that's typically found in cities, families need to make sure that their elder family members have access to timely care. Falls and injuries are very common, and though these may be non-fatal, they can lead to disabilities in the elderly. The most common of which are farming accidents, but also traffic accidents and falls in older people with frailty and weakness or mental problems. In terms of chronic and terminal illnesses, elderly clients are at high risk of chronic illnesses due to non-communicable conditions such as heart disease, cancer, respiratory illness and diabetes. Those are the most common ones. Village health workers need to provide limited support, but ensure that self-care and access to services is in place, and support the families to ensure that. An elderly person may be diagnosed with chronic or serious terminal illness which cannot be treated, or whose treatments would severely prejudice the quality of life of the individual. So in that case, village health workers need to work closely with family members to ensure appropriate home support and palliative care. An important role of the village health worker is to look at the living conditions of the elderly. Elderly people, especially those who are not living with younger family members, often experience poor living conditions which can exacerbate or be exacerbated by their health problems. So the first one is access to safe water, sanitation and hygiene. So less than 1 in 10 of the elderly have access to improved latrines in rural areas. They are often less able to do the construction or installation of piped or protected springs, and less able to bring safe drinking water into the house. So they typically tend to make do. So it's really important that the village health worker identifies those elderly that need support and that community support is garnered to install proper safe water, sanitation and hygiene facilities for them. There will be a loss of food and income security for most elderly people, and they will become increasingly dependent on a staple diet with less access to fruit and vegetables and protein-based foods. Many old people only farm in very small subsistence areas or don't actually own their own land, but much of the food in households can be purchased rather than grown, leaving them vulnerable to changing market prices. Household composition can be a problem, so especially where adults have left rural areas to go to cities and work, we see a lot of elderly people caring for young people, children and even babies, and also a lot of adults living alone, so that could be a cause for concern. Housing conditions. So one issue can be overcrowding, many elderly people sharing room with other relatives. And we need to look at the conditions of the floors. For example, earthen floors can be particularly vulnerable to damp and to fungal infestations, which then cause lung and respiratory problems and increase the risk of fatal pneumonia in the elderly. Solid fuel use and non-clean cook stoves. Well, in Lesotho, most rural area households are using solid fuel. And older people are at particular risk of respiratory illness, and they've often had a lifetime of using wood and coal and cooking inside their houses. And they typically use old style cook stoves and cook indoors. So what needs to be done here is to encourage them to cook and burn fuel outside of their house or in a well ventilated area. And also to encourage them to use the cleaner type of cook stoves or even gas cook stoves that can limit the impact that they have on respiratory illness, especially for those people who've got chronic respiratory problems. Transport is likely to be an issue, and there are long distances to walk, and they can be a problem for people with poor mobility. And lastly, low income. So if there's no social security or family members are no longer supporting them and they can't do their agricultural activities, they can get into a situation of extreme poverty and crisis. So I want you to do activity 3 and think about those risk factors, and let's complete the third column in the table, which is what are the health risks of each of these situations. Pause the video now and proceed when you're ready. So, what is the role of the village health worker? So during household visits, the village health workers need to conduct a check for all of the elderly people living in the household. They need to ensure that everybody has had a recent health checkup. That means a full checkup at a health facility within the last 6 months. We need to make sure that all of their health and support needs are met, that they have sound nutrition and good food security, and hopefully healthy and active lifestyle still, and free from disability. We need to promote good health practices for our older adults, but in particular we need to identify those who are living in difficult conditions or have unmet healthcare needs. So village health workers can provide some limited support to the elderly, but that should always include an assessment of the health, hygiene and nutrition conditions and their living conditions in the home. Any identified gaps should be addressed through community mobilisation or through garnering family support. Village health workers must promote regular checkups, especially if they have any chronic health condition, and make sure that they have good access. And if they are not accessing those health services for some reason, again, garner family support to make sure that somebody's able to take them to the health facility. If needs be, we need to make sure that village health workers, supervisors or outreach workers visit certain priority cases. So particularly in the event that we have someone with severe disability or palliative care, we need to get those priority cases visited in the home. And lastly, we have the promotion of basic good nutrition and healthy lifestyle. I just want to skip forward to activity 6 at this point to reflect on the process of palliative care. So palliative care is the holistic care of individuals with chronic and terminal illness and the care provided to their families. It's a very far-reaching concept which embraces all the physical, emotional and spiritual needs of individuals in the final stage of life. So the objective of providing palliative care in the community, first and foremost, is just to improve the quality of life for the patient and the carers facing the life-threatening illness. And secondly, is to ensure the relief of suffering through early identification and treatment of pain. And by that we mean pain in the spiritual, psychological, social and physical dimensions. So we're introducing the village health workers to the concept of total pain. In terms of total pain, we need to address the various dimensions of pain, but it's not just physical. Physical pain is often the first identified issue. However, beneath that there can be psychological pains which come from facing life-threatening illness. So anxiety, fear about suffering from depression itself, and the past experience of diseases that can psychologically affect the individual. In terms of the social pain, there's loss of a role in the home, there's a loss of status that a person has to deal with. They may often lose their job and experience severe financial difficulties. And then they're going to have worries as well about how they can provide for the family in the future once they're gone. In the spiritual dimension, people experience a range of really complex responses to learning about their terminal condition. They can often experience a shift in their faith. So they may experience a loss of faith or anger towards God and anger about their religious beliefs, and a sense of a loss of meaning of life, and generally speaking a fear of unknown. So what can a village health worker do? Well, the village health worker will need to use a range of therapies to alleviate pain, including the psychological first aid skills that they have been trained on in TTC, or will be trained on in TTC. They need to support the individual and the family members to understand and accept the circumstances that they're in. They can provide psychosocial support to individuals in acute distress. They can also broker family support for those clients who don't have adequate home-based care. They should always be the mediation point between health services and home-based care services, particularly in terms of accessing medical interventions such as pain relief. And also they need to keep an eye on the nutrition and hygiene that is being maintained predominantly by the caregivers in the home. So we talk about triangulating the needs. So whilst the medical needs may be the focus of a village health worker, they also need to triangulate that against social and mental or psychosocial needs. So let's think about those. Somebody who is facing terminal illness, they have immediate physical or medical needs. So they need access to medical care. They need adequate pain relief and control of any other symptoms that they're experiencing to the best of the abilities of the health services. They may need practical advice or equipment to support improved home-based care. We need to ensure that people who are bed-bound are regularly turned and given good hygiene so that prevents the appearance of bed sores, which can cause even greater discomfort, and also observing good nutrition and hygiene. Mental health and psychosocial needs of people, first and foremost, everybody, but particularly people facing terminal illness, need to be listened to. They need to be given an opportunity to talk about their feelings, to ventilate their feelings, which means just to give them air. We need to be accessible to them and open to what their needs might be. There needs to be a continuity of the relationship with the care services, and the village health worker can perform a really vital role in mediating that. They will often want to discuss their fears, not in front of their family, so having somebody that they can talk to confidentially and non-judgmentally would be really important. But they also need to access faith communities at home to ensure the enhancement of their spiritual life, and that may mean bringing faith leaders into the home to support that person, but it could also mean just sitting and praying together. In terms of their social needs, well, first and foremost, we need to have the carers' needs assessed. So who is providing the immediate care for this terminally ill patient? We need to help the families to prepare both mentally and financially for the death. Provide information on what to do after the death happens, and also look for income support if needed, and access social protection or welfare if it's available. If there are children directly affected by the death, we need to ensure child protection or child support is in place. Wider caregiver need to access wider support from faith communities and community at large, perhaps to help with food security or farming during this difficult time. So you can see that a village health worker could have a real range of activities around supporting somebody at the end of their life. Okay, we can go back to activity 4 and the actions for elderly care in the household visit. I've presented alongside the adult essential care actions as well. So you can see that these are not completely separate because elderly are also adults, so they may need access to those services as well. So what's going to happen during the household check is that we'll be speaking with the elderly people directly or in the presence of caregivers if that elderly person is unable to respond for themselves. So the first question is around routine checkup. We're recommending that they have a routine checkup that looks at blood pressure, eyesight and hearing in particular, and any other health concerns every 6 months. If they have any particular health concerns that they have not already sought care for, we can make a referral. And we can look at their health card or referral notes and ask about the appearance of any non-communicable diseases that they may have. We need to talk to them about home-based care. So are they able to care for themselves? Are there any issues or factors which prevent them from looking after their own needs? And also we can make observations around the household to see that they are comfortable, that they are clean, well nourished and able to walk around without any help. How is their communication? Are they able to talk clearly? Are they able to communicate their needs? If not, then there could be an unmet need for home-based care and support. So we need to look at the opportunities for home-based care, primarily from their family, but secondarily from the community if needs be. The third point we're going to look at is healthy lifestyle. So that's encompassing various issues such as being able to get out each day and do some physical activity. Maintaining physical activity is important not just for preventing non-communicable diseases, but improving their mental health and well-being as well. Healthy eating and avoiding alcohol consumption and smoking is very important to stay healthy in the elder years. Good nutrition. So look at their diets, ask about salt and saturated fat, ask about portions of fruit and vegetables, and are they eating every day a balanced diet. You also need to take account of the observation of the elderly person, and you can even do MUAC screening to have a look to see if that person is underweight or obese. So if there is a dietary issue there, that they are low weight or they're obese, you can also counsel that person in terms of improving their dietary composition. Lastly, disability. For this one, we're just identifying older adults in the household who have any impairments, physical, mental, eyesight or hearing loss. Reflecting back on health for adults, you'll see that some of those are consistent. So healthy lifestyles that we've already looked at, that's an issue for all adults. And then for adults, we also include access to family planning, HIV and screening for TB. TB is an illness that affects elderly in particular as well, so we also need to check that they have been screened for TB recently. Okay, so that concludes the session on elderly care. So let's go through just the key concepts here. So, during a household visit, village health workers need to conduct a health check for all elderly people in the home, ask about checkups, home-based support, nutrition, lifestyle and disabilities. The purpose here is to check for unmet health needs in individuals and identify those living in difficult living conditions. Living conditions impact the health of older adults in particular. So in addition to all of this information, we will still have already conducted the water, sanitation, hygiene and food security assessments at the beginning of the household visit. These are particularly important for the elderly who may experience poor or unhygienic conditions. When providing palliative care, the village health worker needs to conduct an assessment of the needs of the patient, including the social, medical and mental or psychosocial support that they need, and make sure that we are linking them into community-based support and health facilities. Support a family to ensure that there is a dignified, hygienic home care, and support is on hand to the clients and families as needed. Okay, so we've completed Unit 4, so we've taken a holistic look at the key health actions for each member of the family. Unit 5 addresses sexual and reproductive health and comprises 2 sessions, which is Session 1, Family Planning and the Provision of Contraception in the Community, and Session 2, which is around promotion of sexual health and HIV testing in particular. So we're not going to cover these topics in the classroom because we believe that they've been well covered in your training in the past and there's no new content here. So what we'd like to do is just spend 15 minutes reviewing the technical content together in your groups. I want you to discuss together if there are any new or unfamiliar areas and highlight those to the facilitators. And thirdly, I want you to just discuss the role of the village health worker in direct provision of family planning commodities during the household visits. Who can they provide to and what commodities can they provide? Okay, so that's it for this discussion. See you in the next unit, which is Unit 6, Community-Based Care. Thank you.